Next speaker is Dr. Rinkal GOYAL. She is going to speak on comparing early surgical outcomes of Phaco Microho with Phaco Bang.
Good morning everyone, I'm Dr. Rinkal Goyal and today I will be talking about the comparison of surgical outcomes between Phaco microhook trabeculotomy with Phaco bent needle goniectomy. I have nil financial disclosures. Oh, PPT is not moving. MIGS procedures address the treatment gap for patients who cannot afford long-term AGM and those who do not need filtering surgeries. These are a group of procedures with high safety profile, minimal disruption of normal anatomy, ab interno approach, good efficacy, and are easy to use for patients and physicians. They work either by increasing the aqueous outflow through the trabecular meshwork or by increasing uveoscleral outflow or by shunting the aqueous into the subconjunctival space or by ciliary process ablation. Both Tenito and Bang work on the trabecular meshwork. The aim of our study is to compare the surgical efficacy and safety of Phaco microlot and Phaco Bang in patients with mild to moderate open-angle glaucoma. Our objectives are to compare the IOP reduction and decrease in the number of anti-glaucoma medication, to assess the complications, interventions, and the visual acuity. This was a prospective interventional comparative RCT, which was done in the glaucoma department of a tertiary eye care institute in South India. Patients aged more than 40 years with visually significant cataract and mild to moderate open-angle glaucoma were included. One-eyed patients, patients with prior glaucoma surgeries, associated retinal pathologies, active inflammation, bleeding diathesis were excluded. Recruited patients underwent Phaco lot or Phaco Bang, which was performed by a single experienced surgeon. Data was collected pre-operatively and post-operatively at day 1, week 2, month 1, 3, and 6 respectively. Recruited patients were randomly allocated to one of the two groups using computer-generated sequences on the day of the surgery. 94 patients were recruited, but finally 70 patients were eligible for analysis in 35 patients with each group, as few patients were lost to follow-up. Success was defined as more than or equal to 6 mmHg or less than or equal to 21 mmHg with more than or equal to 20% reduction in IOP from baseline. If with the use of AGM it was defined as complete success, without the use of AGM was defined as complete success, and with the use of AGM was defined as qualified success. Additionally, there were two more criteria at 25% reduction and 30% reduction. Failure was defined as the inability to meet the criteria, or there was a need of any additional glaucoma surgery or the loss of light perception. Moving to the surgical steps, after adequate peribulbar anesthesia, phacoemulsification with posterior chamber intraocular lens was done. Intraoperative gonioscopy was done using Swan-Jacobs gonial lens, and Tenito microhook was inserted through the clear corneal temporal incision and trabecular meshwork was incised. In the Bang procedure, the needle was bent at 90 degrees with the help of a needle holder, and the needle was inserted through the temporal clear corneal incision to excise the trabecular meshwork. Moving to the result, the mean cup disc ratio was similar in both the groups with 0.72 in group 1 and 0.77 in group 2. And the average mean deviation on HFA was minus 5.06 and 7.23 in group 1 and group 2 respectively. The major diagnosis in both groups was primary open-angle glaucoma, and the male-female ratio was similar in both the groups. There was a significant IOP reduction in both the groups at each visit, with IOP decreased from 24.6 to 11.4 in group 1 and 23.2 to 11.4 in group 2. But there was no statistical significant difference at any visit in both the groups at any visit. There was a decrease in the AGM from 90 to 93.6% at month 6 and 94.8% in group 2 at 6 months, but there was no difference between both the groups. Similarly, there was no difference in both the groups in the best-corrected visual acuity or the HFA characteristics. Moving to the complications, the most common complication noted in both the groups was microhyphema, which was 28.6% in group 1 and 20% in group 2. Macrohyphema was noted in the group 1, that is Phaco lot, for which 2 patients had to undergo resurgery, but there were no major intraoperative complications. Moving to the success criteria, there was no cases of failure according to criteria 1. According to criteria 2, there were 2.8% cases of failure in both the groups, and according to criteria 3, there were 2.8% cases of failure in group 1 and 11.4% cases of failure in group 2. Both the procedures are very economical, as the bang is made from a standard hypodermic 25 gauge needle, which is readily available, while the micro hook is a reusable. Micro hook can be reused after sterilization. There have been multiple articles in the eyes supporting bang and Tanito. So the strength of my study is that the literature in these techniques in Indian population is limited, and to the best of our knowledge, this is the direct study comparing the two procedures. The weakness is the small sample size and the shorter follow-up period. To conclude, both these procedures have a good safety profile with favorable success rate. These are my references. Thank you.
Thank you, Dr. Goyal. Any questions from anyone? You told that literature is very less in this study when Tanito is not available in India, I think, till now. So from where we'll get the literature for this study in Indian population, isn't it?
Yes.
Okay, thank you.